let me bring up. Presentation. Okay. So we talked about a few of these on Tuesday and throughout the class. What I'd like to do now is go kind of through the common relapse prevention skills and whatnot that you would commonly do in a group setting. Okay. So again, for relapse prevention, the effective groups are kind of skill and coping skill based and are meant to provide tools that someone going through addiction can use when the potential of a relapse is occurring, usually when they start to have the cravings, the thought of use, those kinds of things. These are things that they can put in place to slow the craving and hopefully stop it, and then to kind of reframe the situation so it prevents from use, hence the term relapse prevention. Okay. And probably the three most common are these, what they're called protocols right here. Okay. Protocol one is something you do in a group or you teach individuals in the group setting to stop, look, and listen. Okay. So this is one of the kind of first skills is when a participant feels a craving, you encourage them to stop whatever they're doing at that moment. Okay. And then you have them look at objectively at the surrounding situation. Okay. What is it that is basically driving your triggers? What is it about the situation that I'm in that is making me crave? Okay. Now, these seem um, pretty simple because most addicts and people who drink or use drugs tend to think that they know what motivates them to go into use. But what often is discovered in this process is identifying things in the environment that they may have had no idea would trigger them to want to use. Instead, usually what happens is a minute trigger occurs, and then they go through a justification process saying, this is why I want to use right now. Okay. And the reason why I state this is that we often think about emotional triggers, but there's a lot of environmental triggers that go along with it. In fact, one of the most powerful environmental triggers is actually olfactory and smell. Um, that's the most common trigger for addiction. That's also the most common trigger for trauma responses. So it's really about letting them feel the situation, look at it, and then listen to those internal processes and cravings without judgment, saying, okay, we're going through this, we'll be okay. Okay. In the group setting, there's a couple common techniques that are used to do this stop, look, and listen. One is sometimes you'll assign homework where a person has a paper with three columns. And whenever they come up with a trigger, they put the date, the time, and then they put where they were, what they were looking at, what they were doing at the time. So you're the behavior, you're looking at the surroundings, the situation, the people, and then you put your immediate thoughts. Okay. And one of the things that is encouraged in this exercise is you put your immediate thoughts that are unfiltered. So those thoughts we all have that we don't necessarily put into the world. Okay. Um, and so that's kind of one way to get individuals to really take a close look at, from an objective perspective, what is making them trigger and what are the common threads and situations. And that's the next activity behind this homework, is then you go in and you help them find common themes, common people, common sensations, and then you can go in and do further relapse prevention techniques with that. Okay. Within protocol one, there's also some things that therapists and groups often include. For example, you stop, look, and at the listen phase, you might do some mindful technique, where they bring themselves to the current situation. You might do the 5, 4, 3, 2, 1 technique for looking. So name 5 things you see, 4 things you hear, three, and you have them do that kind of formal activities to kind of recenter them into their space. Okay. So that's the first step we use. That's protocol one, as it says in this slide. Protocol two is cognitive restructuring. Now, I want to make this part really clear. I'm going to go back to protocol one. The other thing that you do in the group setting is you'll often role play this. Sometimes it's done using the participant's lived experience. So the therapist might ask, "Did anyone have any cravings this week?" And you take them through and help them practice the stop, look, and listen. You might provide a scenario that is common, and then role play that. And the key is it really depends on the maturation of your group. If you have a group that has difficulty understanding the concepts and whatnot, you may do a guided role play. So you might go, so here's a common situation. In that situation, I would stop and I'd look around, and maybe you do one of those 5, 4, 3, 2, 1 activities. And then I listen, bring myself to the center, do more mindfulness stuff. What am I thinking about? Why is this I'm thinking about this? Okay. And so role playing is an important part, and it'll become an important part of all of these. Okay. Protocol two is cognitive restructuring. And this is where you would use a lot of those skills that we talked about, such as reflection, paraphrasing, all of those things, so that one, the client hears, they put up that mirror of what they're saying, and then you do things like challenging, you do things like rethinking about it, those kinds of things. And so you actively challenge those catastrophic thoughts like, I am a failure. Well, let's look at that. Why do you think you're a failure? Da da da. And you challenge those. And then you also try to help them reframe events using compensatory models. For example, a relapse is a mistake in coping. It's not a defect in your character. It's not because there's your personality or your disposition did that because you're not a good person. It was a mistake in coping with that situation. Okay. And again, this one is about lifting that self-efficacy. Cognitive restructuring should only really occur. It's an important part of cognitive behavioral therapy, but it should occur when you know you have a therapeutic alliance, a trusting relationship between you and the client with the group members. Okay. Because a lot of times you can enter in this in too early of a phase, and it really feels really kind of fake to the client. Okay. And then the last protocol in going through the relapse process is to ask for help. So you review sequence of events leading up to a lapse with your sponsor or therapist, or you have the client keep calm, renew commitment, implement your pre-arranged relapse plan. So you get them to reach out to someone, you get them to make a renewed commitment, again, emphasizing that it's not a defect. This is where the relapse prevention contract that we talked about comes into play. And so, but again, you should probably in the group setting, we have individuals role play this right down to the point that let's say you had one client who had a lapse situation, and so you have them role play reaching out to another group member. What would you say to them? What would you explain? And you have the other group member uh, role play being that receptive, supportive person for them. So you role play these things in the group setting. Okay. The reason this is important and the reason why we emphasize the thing of role play is that most everyone gets programmed, I'm going to put it in computing terms, to do a script when something happens. And it's incredibly hard to break an addictive script that your brain has learned. And so a lot of times these skills take training, 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 practice, practice, practice. Okay. I kind of liken it to if you've been in the military, if you know someone in the military, you know that they train, 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 train. Why? Because it's not really within human nature to go into a conflict zone where you might have to take another human life. So the training is to override those apprehensions, those moral grounds that you shouldn't be doing this, so that in that battlefield, you and your um, um, uh, fellow soldiers will survive. Okay, and without that training, uh, we probably that will probably be the losing side of a conflict. Okay. And this is the same thing. You're training, 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 and helping them rehearse over and over and over. So when they are in their battlefield dealing with addiction, they don't go back to those default thinking, those default behaviors that has led to the addictive process in the past. This is not something that is knock it off, just stop drinking type of situation. Okay. Some other things that are often used in those protocols is coming up with a decision-making matrix. Okay. So this is pre-planning for high-risk thoughts. And this is something that you can actually help create a visual where you have the person put the situation, and then they might have one, two, three arrows, what they can do. And if those arrows don't work out, what could they do from there? So that they have a decision tree. So what this does is, let's say we have a relapse situation and they try road one, but road one doesn't work. So then they can try road two. And if two doesn't work, they can try three. And you'd be willing to bet along that line, one of those decision matrix is going to work out for them. Okay. But even at that, so that's first layer of defense, as I call it. And then from one, you have them, okay, so one didn't work, two didn't work, three didn't work, but two was kind of the best route. So you might go down to a second layer of decisions. What do you do from there? Okay. And again, it kind of goes along with that protocol. Stop. Okay. What are my options right now? Uh, um, I already forgot. Uh, Look what's around me. What are my options for me around me? And then listen, what are my thoughts? And having a decision matrix based on all of those. Okay. Another common technique is reminder cards. These are physical notes placed throughout the home that detail, and this is an important perspective on reminder cards. Often, reminder cards are one sentence, you're strong, you can do this. When we're doing this in relapse prevention, we want those reminder cards to have detail. Okay. So it's detailing the individual's commitment, their emergency protocol, and sometimes that might mean my commitment is my emergency protocol is on the fridge. Go look at it. And then if that doesn't work, having some contact numbers on that card saying, I will call if I can't do one, two, or three. Okay. And this is meant to answer the question, if a person is in a certain place, in a certain situation, what do I do in case of a lapse? What do I do if I'm in this situation and uh, I am at risk of going and drinking? Now, you may think, okay, well, why do we have to put it throughout the house? Okay, why is it that why couldn't we just have a location the person goes to, and that be enough? So they commit, if they're in the bathroom, they'll come out to the living room and read their card. Okay. The reason is within addiction, if a person is kind of in one place for too long and they don't have access to their substance, and they have time to ruminate on it, either on a conscious or an unconscious level. If that is left to stew long enough, that person will implement some plan, again, either unconsciously or consciously, that will drive them towards a lapse. Okay. So if you're, especially if you're one of those people that spend a long time in the bathroom, having a card there is extremely important. Bedrooms, extremely important. Common living areas, kitchen, living room are important places because a lot of times if you're left there to stew while you're having triggers, this can lead to an unconscious or conscious drive to go through a planned way to obtain your substance. And then the last thing that we often do, especially when we're getting through uh, near the end, is a relapse contract. Okay. And this is a prearranged agreement designed to artificially limit the extent of use of lapse occurs, preventing the rapid downward slide into total collapse state. So this is where the client is making a contract that they sign. So it makes it a kind of a legitimate document for them that if they go through a relapse process, these are the things that they will do. Okay. And in a lot of situations, the therapist will sign it. In some groups situations, I necessarily haven't done this, but group members sometimes will sign as witnesses to their contract. So they've made a social contract with everyone, which tends to be a bit more powerful than just the individual and the therapist. And so there's different ways you can establish that, but this is kind of that kind of, especially when they're about to leave the group or leave the treatment. This is kind of a good way to continue that commitment they've been making while in the group. Okay, So what is some evidence for these relapse prevention? And it is pretty stark. So on the horizontal line, we have percentage baseline drinking. On the vertical line, I think I got those backwards. It's the months of treatment. So we have 0 to 12 months. And you can see that while in a control group, so this would be like a alcohol education group, we do see a rapid increase around the 3 to 6 month of use. So it spikes around the third month, where we go from initial drinking of 50 up to 70. Okay. But there is some good news is over time we do see it reduced to about 40%. So from our baseline at the beginning, 50, it can reduce it by about 10%. Okay. The effectiveness of relapse prevention is that we see a rapid reduction almost to zero. And the encouraging component is that 6 months with continued relapse prevention, we find that that is when relapse, the least amount of drinks are consumed. And there's a slight increase to about 10%. So again, if we're measuring it by the number of drinks, we go from 50 down to 10 with relapse prevention. Without relapse prevention, we go from about 50 to about 40. Okay. Um, so we can see that it does have some pretty good effectiveness. And then this one has to do with aversion therapy versus relapse prevention outcomes. So conversions therapy is when you do exposure and then you have something aversive occur in the individual. So, for example, some of the first pharmacology for alcoholics was a pill that made the addict nauseous if they consumed alcohol. So this was kind of a form of aversion. They want to not experience that again. Okay. The other forms of aversion is exposure and then negative consequence of some type. So, what they found in a meta-analysis is that relapse prevention tends to again be more effective. So, we have months of treatment, baseline percentage baseline of drinking. So you can see aversion therapy works good, almost as good as relapse prevention up to the third month, but then it skyrockets up after that. Where in this graph, it shows that relapse prevention stays pretty consistently low, under 10%. Again, this one goes from 60 to 10%, which is significant. Okay. What they did find in this research and why we're talking about this, especially in the group setting, is they did find that the group format is more effective than the individual therapy format. Okay. And inpatient settings yielded significantly better outcomes than outpatient. Okay. And this is why in a lot of treatment, they do inpatient for 30 days, and then they do what's called intensive hospitalization, where the person lives at home, but they go to the treatment center at least 5 days a week for the majority of the day. And then they go to what's called IOP, which is intensive outpatient treatment, where it's 3 days a week, and they do that anywhere from 30 to 60 days. They're finding that this gradual transition from complete inpatient to outpatient has better effects. Okay. Application. Um, Stronger treatment effects found for broader substance use than isolated to alcohol abuse. And the important part about this is that while a lot of the research has been done on alcohol abuse, we're finding that this relapse prevention process is effective for other substances as well. Okay. So So this is kind of what we're doing in the group setting when we're talking about relapse prevention, okay, is helping our participants understand that recovery is not a straight line. You don't go from 100 to 0 miles per hour in one day, and that a lapse is not a collapse, okay? That when a person has a lapse of, and I don't even want to use the word judgment, a lapse of a situation that drives them to drink at one point, that doesn't necessarily mean that they're going to go through the complete addictive process. Okay. So this is a shifting framework, as this bullet point says, from a moral failure to a mistake in coping. Relapse prevention is meant to short circuit that abstinence violation effect. That, oh my gosh, I drank and therefore I am an addict and this is just something I can't control. And so I might as well just continue drinking. Okay. Or using, as we said in that last slide. And the second bullet point is that ultimately objective of these interventions, and now I'm reading a slide, is not merely sustaining abstinence. And this is important. It's about reclaiming one's self-efficacy, that you are more than your addiction. You're a person that can make choices for your life, for your world. And as this last part, and I'm going to read it because I really like it, it's moving the patient from being defined by a condition to mastering the map of their own life. Okay. And that's really what we want, is people who have effective coping skills, effective trigger reduction skills, so that their addiction doesn't own them. It is something they just have to work on and overcome. Okay. So, okay. So that is the application to